was taking a long time to pull up. I think I'm going to pull it over here. All right, are we set? Can you see that?
Yeah, we can see it.
Okay. So did you do this yesterday as well? The indices, like scoring it?
Yeah.
Yeah, we did that.
Good. All right. So I'm not going to go through this entire chapter. Let's say that I'm going to go through pretty fast. There's some things that you need to know on here, but most of these different indices you're going to get in public health with Dr. Thurlow, and she goes over a lot of these, so I'm not that concerned about those, the majority of them at this particular time. So the individual assessment score, the scoring system is for patient education. And that's, we like to be able to give them something. There's nothing like them being able to take a mirror and look at the disclosed areas on the teeth, and then look at your scoring system and you give them a percentage. That can be eye-opening to some patients. It's to help motivate and also to evaluate. So you give them this great motivation and they come back the very next time and you just close again and see if it's any different. So they have clinical trials, and which determines a baseline full of data on some procedure or some progression or control of some disease. It could be caries, etc. So you compare a control group and an experimental group, and it would measure the effectiveness of the, like, if you're looking about toothbrushes or irrigators or biofilm or caries, whatever. So epidemiology or epidemiologic surveys is the study of disease characteristics of populations rather than individuals. So you need to know that. I'm pretty sure on your study guide, it could be such as decayed, missing, and filled teeth, etc. You could have many things going into that study of disease in populations. So it just determines the extent maybe of dental caries in a certain population. Could be an underserved population. So community surveillance, the purpose is to collect, that should be data to determine oral health status of a given population. So you conduct a screening. And this is what I hope that, you know, this COVID is managed better before you guys graduate, so that you have the opportunity to go to the schools and do some screenings. They're a lot of fun, and you learn good stuff. So we do this to assess the needs of the community, or to plan a particular promotion or a disease prevention program, and also to compare the effects or evaluate results of community-based programs. And you can get funding sometimes due to these community surveillance things, if you get a lot of really good data and have it over a while, you can have your advocates take it to the state and advocate for particular underserved areas due to your study to maybe have more visits from dental school students or whatever, you know. When we go out to the which we can't do now to COVID, but we go to the Royals, we go to always have gone to the Chiefs and to the soccer. So stadiums. So 3 times a year, it's kind of like spring, summer, and fall. We go to one of those 3 and we put on, along with a lot of all the other schools and volunteers, there's tons of people there. And they bus in students, from underserved schools. And so they come in, we have hygiene set up there with our units, and a lot of times they're on like lounge chair type of things, but we give them a cleaning. They have x-ray stations, multiple ones of those. They have a lot of dentists that volunteer their time to do free fillings and extractions, etc. So they're a lot of fun. You use, we're able to do a lot of that kind of things due to many of these programs and surveys that have gone out that have proved that we need the funding for this. So it's a good thing. So indices, what are they? They're an expression of clinical observations by using numbers. So you saw yesterday how we did an expression of clinical observation of your plaque control, and we calculated that ultimately into a percent. So that's what all of the indices are. That they have many different indices that are calculated in many different ways, and sometimes it is for an individual or it could be a group being measured. So for all of the different indices they have to have like a control group or a standardized method for a way of interpreting that. So it's less subjective than a word description. You could, we still need a word description like in your soap notes, but there's nothing that can argue with someone has an 80% plaque index. There's just, you could be explaining that would take a small paragraph, and 80% kind of speaks on its own. We all know what that is. So oral hygiene status, we could be checking their biofilm, debris, calculus, many different things. So different kinds of indices they have a simple, a cumulative, irreversible, and reversible. So a simple measures the presence or absence of a condition, like biofilm index measures the presence but not the effect on the gingiva. So that person may have an 80% biofilm index or percentage, but their gum tissue is probably being greatly changed for the worse, being next to all that biofilm, if that's any indication of how they normally take care of their teeth. So a cumulative index measures the present and past of a condition, like index for dental caries would maybe be a cumulative. You check it this year and maybe last year. You check it every 6 months when they come, maybe have some kind of a, and check what they have today as what they had before. So irreversible would be dental caries expressly. It measures conditions that will not change. So periodontitis would be one. They'll have different levels maybe of perio issues, but once you have it, you have it. And dental carie, as long as it's not incipient or just a demineralized little spot, but actual dental caries are dental caries. So reversible would be the plaque. It would be a simple and reversible index if you were just measuring plaque, because that's a measured condition that can be changed. Selection criteria when they're coming up with these indices and the way to calculate them, they have to have a certain criteria met. And what that is, it needs to be very simple, so anybody could use it. It needs to be free, no charge, no pain on the patient in order to gather your data. It needs to be valid, reproducible. In other words, that you could, if yesterday Jaden did Hunter's teeth and she put plaque disclosing solution all over that, and she did her calculations, and right after that, maybe we waited till let her brush her teeth or whatever, and then we had Kelly go do the same thing on the same patient. It should be reproducible. You should be able to get some of the same indicators, and you should be able to do it correctly time after time on anybody. Uses a minimal amount of time, needs to be something quick and very clear-cut way to do it are some of the criterias. So the plaque biofilm control, the purpose is to record biofilm on an individual tooth surfaces. And so our patient can see that and become aware of it and hopefully better their home care. So the selection of teeth and surfaces, we want to do all teeth. There's 4 surfaces recorded, as you saw yesterday: the facial, the lingual, the mesial, and the distal. 6 areas may be recorded. Concord uses 6 areas. There are some index that use 4 areas on the tooth and not all 6. So we call it a PI for short, which means plaque index. So in your notes, you will see PI percentage, which means their plaque index. So I think you saw all this. I won't go through the procedure, but you see how the calculation, like I was telling you, is right on the paper. So you don't have to remember it. So how do you interpret that? So if you have, obviously, tell a patient they have 0% plaque, that would be ideal. If it's less than 10% biofilm stained surfaces, has been suggested as a guideline of periotherapy. So when they want a perio patient to always try to remain in less than 10% of biofilm on their teeth. When the patient has reached 10% level of biofilm control or better, additional perio and restorative procedures may be initiated. So this would be somebody who had a very hot, like 50% biofilm, 40% biofilm. It's almost half of their mouth. They also have perio issues, and they have fillings that need to be done, and their gums, they have severe gingivitis because of all this biofilm. So we would want to do some tissue conditioning and get them on some kind of even if it's like a 2 to 3 week schedule at home to better their home care. And then if they come back and they've reached less than 10% and the gums are healed up, then they can go on with their other procedures. And that's what that means. So they also have a debris index. The debris index would be, each number below would be counted as one surface. So it doesn't matter how much you have on the tooth. If it's on that surface of the facial surface at all, it would all 3 of these would be counted as 1. So it's a simplified oral hygiene index. You do 6 teeth are scored, and a scoring of 0 to 3 is based on tooth surfaces covered by debris as shown. We don't do the debris index, but I'm just wanting to show you that they have different indexes that people do. This is a calculus index sample. It's a simplified oral hygiene index. 6 teeth are scored, and also a scoring of 0 to 3 is based on location and tooth surface area with calculus as shown. So note the slight subgingival calculus recorded as a 2, and more extensive subcalculus is a 3. If they had that. So they have indices that measure gingival and periodontal health. It could be a papillary marginal attached index by Schauer and Massler. Periodontal index, they also call that a PI by Russell. Other indices for patient instruction. So I want you to be aware of, I think we might have shown this before, it's a WHO probe, and it's the World Health Organization is what the acronym WHO stands for, and it has a little ball at the end. These are generally used for a particular bleeding index called the PSR, and they do their bleeding indexes a little differently. They use a special probe. Bleeding on probing indicates usually that there's gingival inflammation and progression of perio disease. Let me get this in. So it's very important. And they score it a different way. PSR stands for periodontal screening and recording. They want to assess the perio health, and they divide the tooth or the mouth into sextants. So they have loss of attachment codes. We call it CAL, but you could, same thing would be loss of attachment, LOA, I guess, if you wanted to. And they have different codes you can kind of read in here. This is another special type of indice. Then we have the bleeding index, which I've seen in review books. It's called the Eastman Interdental Bleeding Index example. This is going to be an index to assess inflammation and bleeding. So they take a wedge, and you have the patient wet the end of the wedge, just make it a little soft, and then you pull it. You just put it in and out of all the embrasures. And where it's bleeding, then you would take a particular kind of score, but that's the Eastman type. So other types, dental caries, experience root caries, dental fluorosis, the WHO, World Health Organization, basic screening, sulcus bleeding, PSR, gingival perio health, simplified oral hygiene indexes, biofilm free score, et cetera, et cetera, et cetera. So factors to teach the patient, we would want to tell them why we are going to be putting a staining solution on their teeth. Most people have heard of this before, but we do have people from other countries that come into our clinic that may not be aware. So instead of just putting it on them, expecting them to know, just make sure that you are telling them if they have an interpreter. Some people that we come in that speak Spanish, they can understand more than they can speak. So it's just in getting, knowing kind of how to be with your particular patient. Any question on that? Okay, we're going to go ahead with fluorides. Fluorides, I would expect on fluorides that there would be, I know that a lot of boards have the different tests. I think we've talked before about students will come back and say mine was, had a little of everything, but mostly the more was radiology and public health. And somebody else will come back and say it was basic dental hygiene and perio or whatever. But fluorides are something that is so key to our industry. I would, you're going to have fluorides in some way or another in a lot of your other classes. And so hopefully by the time it will just be reiterating it and reiterating different aspects of fluorides so that you'll be prepared like our other students have been for boards. So fluoride is available to the tooth surface in two ways, either systematically or topically. So it's either going to be by way of circulation to the developing teeth. It could be in a supplement, in the water. It's something that's in your system. So, or topically, which did you get to do the fluoride on each other yesterday?
Yes.
Oh, good. They did get it all done. Okay. So they're directly to exposed surfaces of teeth erupted into the oral cavity. So it's going to be post-eruptive. If you get a funky question, that will phrase it that way. Obviously, it's not in utero, and so it can only be given topically post-eruptive when the teeth are in the mouth. So the maximum caries inhibiting effect occurs when there is a systematic exposure before tooth eruption and frequent topical fluoride exposure throughout life. So a systematic exposure before tooth eruption. So what they're talking about is a pregnant woman, and they are hold on, I think I need to correct that. I think that should be after tooth eruption. Occurs after tooth eruption. I think I need to fix that. It's after tooth eruption and frequent topical fluoride exposure throughout life. You get your maximum caries inhibiting effect. I know that pregnancy, they don't want, well, there's no need for pregnant women to take supplements because they're not concerned about the primary teeth. We'll get into that a little later, as much as they are the permanent teeth, and permanent teeth don't start forming until birth. So the fact that they would take these vitamins to help their permanent teeth is a moot point. It's not doing that until a baby is born, when the permanent teeth start forming. So fluoride intake on the metabolism, systemic nutrient taken into the body by water that contains fluoride naturally or has been fluoridated from dietary supplements and in small amounts from foods and toothpaste, mouthwashes, etc. So we have a lot of different ways to take up the fluorides. So in our water system, we have fluoride naturally. There are places who have more of it naturally, and they have not added any fluoride to it. I think this book talks about later about a place in Colorado whose natural fluoride was way over the limit. Like they had a lot of people coming out with dental fluorosis. It wasn't because the water companies added anything to it. It occurred naturally in their drinking water. So a lot of times there's not enough fluoride in the natural fluoride in the water, and so they add fluoride in the water. So absorption, most of the fluoride is absorbed in the GI tract, in the stomach and intestines within 60 minutes. So the remainder is in the small intestine, less absorption when taken with milk and other food. So milk binds with the fluoride, and so makes it less productive. So you don't want to take, if anyone's taking any fluoride supplements, don't drink it. It's not even with just milk, it's dairy in particular. So distribution and retention by the plasma to all tissues and organs, it goes everywhere. The maximum blood levels reached within 30 minutes. So there's a strong affinity for this fluoride. It goes for the calcified tissues, which are your bones and your teeth and the enamel. 99% of fluoride is in your body is located in mineralized tissues. So hardened tissues like that, your teeth, your bones. The highest level on the tooth surface is where there's more fluoride on your tooth surface and than there is in your bones. So this is why we get particularly antsy when people are polishing on the tooth, because polishing only removes just micrometers from the surface of the tooth, and most people are getting their teeth cleaned twice a year. It's like it's maybe not a big deal, but when you hear someone that is really pushing hard and they are, you know, it should be with a firm but light grasp and pressure on the tooth, and when they're doing more and just have the speed up super high and running fast, it can take off a little bit more. And I know they're just micrometers, but you need to look at also the patients that are coming in 4 times a year. They come in every 3 months, which is 4 times a year for perio maintenance. And so if you are going to be polishing at all those appointments, the idea is that every other one you will use grit, and then you'll just use like maybe toothpaste, something that's not bearing down on the teeth that much if the patient wants it, because polishing, people expect that if they are having their teeth cleaned. But it's surprising, we've started talking to more patients in the clinic about it's just aesthetic. It doesn't, I mean, you clean the teeth off and polish them, and what's back in, you know, minutes or under a minute, the pellicle and biofilm and on all of that. So it's not like you're going to keep it off. It's mainly they want it done for stain and just brighten their teeth. But you'd be surprised how many have said, no, just don't polish. And so that used to be a huge no-no. It is not considered that today. So we're very in tune to how many times we're polishing the teeth and possibly taking off just micrometers. You're going to say if someone starts at 12 years old or however, whenever they start getting a full polishing twice a year, and they live till 90, that's a lot of surface, and that outer surface of your enamel is the most rich. It's the most fluoride rich, and so you're removing that. So it's all of concern. So excretion, fluoride is excreted through the kidneys and the urine. A small amount is excreted through our sweat glands and feces. There's a limited transfer from the plasma to breast milk for excretion. It's essential to the formation of sound teeth and bones, as are calcium and phosphorus, which are in your teeth as well, are in your enamel, and other minerals obtained in food and water. So fluoride in tooth development, there's a pre-eruptive stage, the mineralization stage, deposited during formation of the enamel, also results in shallower occlusal grooves and reducing caries. This is the pre-eruptive. The first permanent molars begin to mineralize at birth, and so the fluorosis from excess fluoride and inhibiting activity of ameloblasts and crystal growth. Okay, so blah, blah, blah. What that means is when they start to mineralize at birth, if you're in a place that has excess fluoride, it would be a time in your breastfeeding or whatever. It's a time to really think about the excess fluoride in like the water, I know, but fluoride actually at that time will inhibit all of the ameloblasts and crystal growth. And remember that ameloblasts has to do with enamel. Anything amello has to do with enamel. So all of those hyperplasia and localized hyperplasia has to do with the ameloblasts during formation being like what they call insulted or inhibited activity of them. And then you can start having and crystal growth right when that's forming. So maybe when the teeth come in, then they're spotted. So the maturation stage, the fluoride continues in the surface of the enamel after the tooth matures and before eruption. So post-eruptive, this is throughout lifespan of teeth from water and mouthwashes, toothpaste, etc., rinses and varnish. So systemic fluoride uptake most rapid on the surface of the teeth during the first years after eruption. So it will show you the mineralized stage and all the ameloblasts that are helping the enamel form. And then if there's a high fever or some kind of insult, they call it, or disruption to these ameloblasts, then the enamel is not forming correctly as it should, and the dentin is forming, and you've got all this fluoride helping the ameloblasts. So this is when it's maturing and it's getting closer to the erupting through the tissue. And then you have the erupted tooth that's come through the tissue, and now you have the papilla on each side as well. For dentin, the highest concentration is at the pulpal level. So the highest concentration of fluoride, here's the fluoride on the outer surface, all these little, I don't know, turquoise dots or green dots, whatever they are. And then you have the enamel underneath it. So we would like to keep this fluoride-rich outer covering on the enamel as much as that we can. And then the dentin concentration is highest at the pulpal level. So uptake of fluoride depends on the level of fluoride in the oral environment and the length of time of exposure. So you can see here the papilla are receding and they're going down. You've had these fibers that have detached, and here's the CEJ right in here. And so there's root showing. The cementum is on top of the dentin, on top of the root. And so it is good for the fluoride to go in there, be absorbed. Tooth surface fluoride, fluoride in the enamel, the uptake, hypomineralization absorbs the fluoride rapidly. So if it's undermineralized, it's meaning it's going to absorb that fluoride very quickly. Fluoride is natural in the enamel surface. Fluoride in the dentin is greater on exposed dentin than in enamel. So it's higher at the pulpal surface. Newly formed dentin absorbs fluoride very rapidly. Fluoride in cementum. The level of fluoride is high and increases with exposure. So on recession, and they've just said that there's a greater, the fluoride is greater on exposed dentin, which means that recession. So the cementum in the dentin is going to have the most. With recession, fluoride is also, the recessive area also gets fluoride from your saliva. So the early stages of a caries with an intact surface enamel and subsurface demineralized area. So this first picture is showing that you have intact surface enamel. These are like little small little microtubules. And here's the demineralized, because we know that decay starts inside. It goes kind of inside out. So it's going to start with this, the lesion is advancing closer to the dentin. And so it's going to show down here a demineralized area. readily takes up all these little dots, the fluoride, and the fluoride content 1,000 parts per million of the relatively intact surface. This is relatively intact because it has these microtubules, and that also helps the fluoride go inside. And here you have, it's actually higher here than on sound surface enamel. On sound surface where there is no demineralized area, and it is there's no microtubules and nothing going inside there, it takes up 500 parts per million. Where when you have this demineralized area, it's going to soak it in, and you'll have 1,000 parts per million on the surface. So the demineralized area is getting 175 parts per million. Even the advanced lesion has 150. Where here's sound enamel, this would be nothing is wrong with it, no demineralizing or anything. 500 parts per million go into sound, and the inner layer would be only 75 parts per million. So it's just a way to kind of show you that when you see those demineralized area, and they say they do not want a fluoride treatment, it gives you another, and we don't argue with our patients, but it's good to let them know that this would be really, really helpful to those demineralized areas, how much it's soaking that in, and could help it kind of turn that around. So demineralization, remineralization. Okay, there's fluoride in your biofilm and your saliva. So that means that there's going to be fluoride in your calculus, because when the biofilm it hardens, it's going to have fluoride in that as well. But fluoride in the biofilm and saliva, it inhibits demineralization during an acid exchange. And so what that means is it's protecting. We've talked about that in other chapters, that your saliva has a protective characteristic to it. So the fluoride enhances remineralization by forming on the crystal surface. And when it forms on that crystal surface, it attracts calcium and phosphate ions. So it's like a triple whammy. Fluoride is in high concentration, interferes with growth of bacteria. Biofilm contains 5 to 50 parts per million fluoride. So the content varies and it constantly changes. So the fluoride may be acquired from water, from mouthwash or toothpaste or whatever, your dentifrice, and other topical sources, and brought to the saliva, or by the exchange of fluoride in the biofilm to the demineralized tooth. So if there's fluoride in your biofilm, it's still not good to have biofilm, but since we all have different, tons of biofilm, but since fluoride is in the biofilm, then it can help the demineralized tooth as well. Fluoridation was named by the U.S. Centers for Disease Control, the CDC, and Prevention as one of the 10 most important public health measures of the 20th century. So if you are in the whole 20th century, they made a lot of strides. A lot of strides in health. And even the CDC is saying that it has helped immeasurably to the point that it is in the top 10 list. That's saying a lot. So community water fluoridation is the most economical systemic fluoride delivery method, so that they could give to communities. Historical aspects, mottled enamel, they had dental fluorosis and fewer dental caries. So historically, in areas that had different parts of the country that had naturally had, we talked about before, excess of fluoride and didn't even have anything added to it. And then there were many parts of the country that had hardly any, to a point that it didn't really give any benefit. So Frederick McKay studied mottled enamel, and he noticed that they were not good looking teeth, but they did not have a lot of decay, and how strong they were due to all that excess fluoride. So H.B. Churchill was a chemist, not the Churchill from England. This is a different Churchill. And he was a chemist, and he isolated fluorine as the cause of the mottled enamel. So then Dr. Dean, in 1930s U.S. Public Health Service, directed by Dean, concluded the below amounts of fluoride in the water were optimum for caries prevention. He said that 1 part per million in moderate climates, and you would have dental fluorosis if you had levels over 2 parts per million. So it gave a kind of like a 1 part to 1.5. They had a big deal with the climates. It depended on what the climate was as to how many parts per million that they may want in the water. So at that time, many communities lived long lives where fluoride was naturally greater than 1 part per million. So they realized that naturally they had 1 part per million, and they didn't have any ill effect, any poisonous effect on the people. So they thought they wanted to add more, just under 2. So they wanted to add a little more fluoride to the water to really help with the decay. So in 1945, fluoridation, first communities were fluoridated and testing began. So now the water supply adjustment. In 2015, that was all of the studies from the early days that we talked about. And so now they have realized that an optimal fluoride is 0.7 part per million to prevent caries and then minimize fluorosis, no matter what the climate is. Okay, so this number, you will need to now be surprised if that wasn't on your boards. I think it's been on almost everybody's boards. What's the optimum fluoride level to prevent caries and minimize fluorosis? 0.7 parts per million. Chemicals were used, sources naturally occurring and mined throughout the world. Effects and benefits of fluoridation. Fluoridated water is a systemic source of fluoride for developing teeth and a topical source on surfaces of erupted teeth throughout life. So appearance of teeth, white, shiny, opaque, and without blemishes. The majority today is mild fluorosis. So these are the effects on fluoridation. In most areas, they have this figured out to where the majority of fluorosis issues today are at least very mild. Sometimes you can't even tell the difference, though maybe just a little few flecks. It isn't like it was before. So the dental caries, permanent teeth, the overall benefits, there are less caries, and those caries are very slowed. Distribution, anterior teeth get the most benefit, especially the maxillary. It receives more protection than the posterior, and that's due to fluoridated water passing over the teeth. So the best results are when you have a continuous use of fluoride in the water from birth. So the tooth loss from caries is reduced. So I know my daughter just, within the last 4.5 years, had 3 kids. So I know that they are not wanting the babies, or at least her doctors, I don't know if this is throughout, didn't want them to drink tap water for like the first, 6 months, a year, something like that. You guys would probably have a better clue of that, but the mother is drinking fluoridated water, and so a little bit of that is at least passing on to the child before they can actually, in a lesser form, if she's breastfeeding. Root caries, approximately 50% less. Root caries have been shown in lifelong residents in a fluoridated community, and so they will always compare when they're doing these studies, a community where no one of the same types and ages, etc., that didn't have any fluoride. So they were able to check that. Partial defluoridation. When water is in excess of natural fluoride, it does not meet the requirements of the United States PSH, so public health system, which is what that stands for. Several hundred communities in the United States had water supplies that naturally contained more than twice the optimum level of fluoride, so they defluoridated it. And so they did it with several chemical systems. Britain, South Dakota has been reduced from almost 7 to parts per million that they had naturally to 1.5 part per million since 1948. Bartlett, Texas, it was naturally in their water 8, and I think I told you guys it went from 8, and now they have it even back in 52, since 1952, it went from 8 to 1.8. So told you guys that I could always tell back in the 70s and 80s kind of where in the country a person was born. I'm like, were you born in the South? Were you born in the far North, West? And they would always be surprised, but you could tell by the way their teeth looked. There's a significant reduction in objectional fluorosis in children now, and that they defluoridated. Then there's school fluoridation. This brings benefits of fluoridation to children in rural areas. This is the situation where the rural area does not, maybe they drink well water and they do not want it fluoridated. So they notice there being tons of decay in the children. And so they voted to bring at least fluoride into the school water. And so it could bring a little bit to the children, increase the amount of fluoridation. And they would only intermittently use it or drink it because I guess in the summer, they got none at all unless they went to summer school, but 5 days out of the week. And depending on how much water that they drank or was the food was cooked in. So school fluoridation has been phased out in several states. I don't think it worked so well. Operations and maintenance of the small fluoridation systems are very problematic and probably way too expensive. So they discontinued fluoridation. Antigua, Wisconsin showed a marked drop in children that were caries free and a steep increase in the decay rate. So when they discontinued that fluoridation then was reinstated in 1966 by popular demand. So fluorides in food. Certain foods contain fluoride, but not enough for decay prevention. Meat, eggs, vegetables, cereals, fruits, tea, and fish. So tea and fish have the highest amounts of fluoride in those foods. Foods cooked in fluoridated water retain the fluoride from the cooking water. So there's a help there. Fluoride in salt. This has not been promoted in the United States, but it is available in Europe. In a lot of countries, 30 to 80% of slat or salt marketed. Let me let this Emily in. Okay. Is fluoridated in a lot of European countries. It's been shown to reduce decay, but there's insufficient evidence for its overall effectiveness. So recommended by the World Health Organization as an alternative to fluoridated water for the underprivileged groups. So if in some of those communities where it was too much management and expensive to keep the fluoride in, it would be an alternative to not having any fluoride at all, or in rural areas, and they're not particularly underprivileged, but it would be for rural areas or the underprivileged areas. So then you have a halo effect. Halo effect would be foods cooked in a fluoridated community taken to the next community that voted against fluoride. And so maybe you have your fast food restaurants, your restaurants, or just people's homes, and they have a big picnic where they're selling food or whatever, and they take them all over to a community that does not have fluoride, or it's too hard to get fluoride to let them have some benefit. Boy, they'd have to be over there a lot with food and drink, right? Okay, so bottled water. Most do not contain fluoride, but I've noticed that you can buy bottled water with fluoride in some places. Water filters, you have a reverse osmosis and water distillation system that removes fluoride from the water, but water softeners do not remove fluoride from the water. I remember that being in that little few sentences there were in some review books about water softeners, not if they were able to remove fluoride from the water. And reverse osmosis and water distillation systems, I've got one set up at my home, and we have one at the clinic, and more people are getting these in addition to their regular tap water. Carbon filters are at the end of the faucet or a pitcher, and they vary. You can get carbon filters that may say that they filter out the fluoride or not. Carbon filters with activated alumina, whatever, removes fluoride. So you need to remember that. And you need to check before purchasing if that's what you're getting a filter for. See if it's taken out the fluoride as well. Instant formula. Breast milk may contain a very smidge amount. It's 0.02, parts per million of fluoride. All types of infant formula, however, contain fluoride. So it would be 0.11 to a 0.57 parts per million. And the American Dental Association advises using tap water with formula. However, buyer beware of possible mild fluorosis. So it depends on where you live, in other words, and how many parts per million is in your drinking water. And it also depends on the baby doctors who might be advising their patients for them to stay away from water or fluoridated water at least. Dietary fluoride supplements. So in the 1940s, supplements were intended to compensate for fluoride deficient drinking water. And the American Dental Association revised the recommendation to include children from 6 months through 1 year, and to include those children at high risk of developing decay, those whose primary source of drinking water is deficient in fluoride. So also remembering not to take the supplements with any dairy. So first you need to assess the possible need of your patient. You review their medical history for possible fluoride supplements. I don't know if I've ever seen, I don't remember. I guess the law of averages I probably have in medical histories, but I just don't recall anyone taking a fluoride supplement. Determine the fluoride levels of all sources of drinking water is below 0.6 parts per million. Request water analysis. Note the risk and have frequent appointments to evaluate. And it means frequent appointments with your dentist. Available forms of supplement. They have a sodium fluoride supplement, or NAF, tabs, lozenges, and drops. So prescribe on an individual basis for home use. Tabs and lozenges. Tabs are chewed thoroughly and forced between the teeth before swallowing. I guess then you get your floss out. Okay, so lozenges dissolve for 1 to 2 minutes to provide the benefits. So you need to keep that in your mouth. Best time is at bedtime and after teeth are brushed, so that you don't have, and you don't rinse any of those out. They're also advising, if you have fluoride in your toothpaste, not to, people usually brush their teeth before they go to bed at night and then take a big glass of water and spit it out, or a big swig of water and spit it out. They're advising not to do that because you're taking all the fluoride. They're saying brush your teeth and just spit into the sink and go to bed. Ugh. Okay, so anyway, drops, primary use for a child 6 months to 3 years of age or any age. Prenatal use by pregnant women is not recommended. There's a weak evidence to support the use of fluoride supplements to prevent caries in primary teeth. Very weak evidence. And plus, as we said before, the permanent teeth start mineralizing and forming at birth. So there's really, they're just taking supplements to take supplements, and it's a moot point. Prescription guidelines. You need to know this. There's no more than 264 milligrams of sodium fluoride, which is 120 milligrams of fluoride, that can be dispensed per household at one time. So you want to take with juice or water, never with dairy, due to combining with calcium and being poorly absorbed. So the storage, dry places and away from children, keep from dampness, heat, and light. Keep it in its original container. If you missed a dose, you take one as soon as remembered. Unless you're near the dose time, skip that dose and go to the next regular time. Benefits and limitations. No benefits to prenatal dietary fluoride supplements, and it's not recommended. I think that's going to be a question on your quiz, actually. So evidence is weak that fluoride prevents primary teeth caries, and that's why. So what is the maximum amount of sodium fluoride that can be dispensed per household at one time? Anybody have an answer?
264.
Yeah. Very good. It is, that amount is below the toxic or lethal doses and therefore eliminates the hazard of storing large amounts in the home. Okay, so professional fluoride applications. Topical fluoride is an essential part of a total prevention program for all ages. Fluoridated topical and fluoride toothpaste are primary sources for all ages and levels of risks. The professional application of a high concentration fluoride preventative agent is based on caries risk assessment. So applied by professional and self-applied, they can self-apply at home. It comes in gels, foams, and varnishes. So the compounds, we have a 2% sodium fluoride that comes in a gel or a foam 2 to 4 times per year. You need trays, mouth trays for that foam. There's limited evidence of a real effectiveness with the foam. Then we have the 1.23 acidulated phosphate fluoride. This is the APF. This you have to watch out for because it etches. That APF can, acidulated phosphate fluoride, can etch restorations, just kind of put tiny scratches in them. And so it is widely used, but you just want to skip those particular teeth. It comes in a gel or a foam. And so if you're going to use it in a foam or a gel, there's a little way that you can, if it's in a tray, there's a little way that you're going to skip any teeth. But it is very widely used. Limited evidence of the foam effectiveness on caries. So one that came about that the first two, sodium fluoride and APF, you do not give to a child under 6. We always tell them not to swallow it, but a lot of times they do. So we do not ever give those underneath a child under 6. But what you can give a child that's even 3 years old, 2 years old, whatever, is you can give varnish, because they don't swallow that. It dries on the tooth. And so varnish has become the new thing for many different reasons. It's usually in a 5% neutral sodium fluoride varnish. It's safe, it's fast, it's easy to apply. There's a higher fluoride concentration in the varnish than gel or foam, but overall less amount of fluoride per application. So releases fluoride over 4 hours, most of them, but you have to look at whoever is making, from the manufacturer who's making your fluoride, which is why I gave you, asked her to give you the assignment of just typing out the fluoride directions. If we start to notice that we're getting a different kind of fluoride from a different company, then we need to look at those directions. Most of them have those little pads where you tear the directions off and you can give to the patient, but 9 times out of 10, it's forgotten, because there's so many things to do before you let the patient go, and they're kept in the, so everybody has access to them. They're kept in the sterilization room. So a lot of times it doesn't get done, and we as instructors have gone around. We hear overhear the weirdest things that people are saying all different times, and what they can do and can't do, etc. So we don't want, I hope you got that. Okay. We don't, that's why I'm having you do that exercise, and it's also going to be counting towards your minutes of what we need to make up. So be sure and don't forget doing that. I think they're going to have the seniors do the same thing. Okay, so I noticed on the instructions I already read, someone did the instructions that I read over them, and I think it says don't brush your teeth for 6 hours. So on that particular one, it's for 6 hours. So you brushed it on the teeth. The only fluoride application that's safe for children under 6. And the fluoride also can penetrate biofilm and pellicle, and those are hard to penetrate with anything, but fluoride goes right through them. So when you are if you're doing a fluoride community project and you're giving fluoride treatments to children looking for decay and maybe giving them a fluoride, they don't have to have just brushed their teeth. I mean, they can have just eaten lunch, and you can put fluoride on, and it will go, especially if it's varnish, because it will move around the tooth with the action of your saliva. So it's very good. So needs, if your office, when you leave here and work out in the real world, if they have trays and they're not covering the whole tooth like this down here, they need to cover all of the teeth. So these are not custom trays, and these may be, they just need to buy a larger size, and I guess they're calling those custom. So here's the low pH of 3.5. That's very acidic. Enhances the fluoride uptake, which is greatest during the first 4 minutes. Fluoride uptake. So this is a particular gel that obviously has to stay, for what, 5 minutes? Fill trays only a third full for children and adults. Then they have silver diamine fluoride for extreme caries risk. Dry mouth or xerostomia, severe early childhood caries or cancer treatment when they've had radiation and chemotherapy and or are currently going through it. It's a treatment challenged by behavioral and medical management. Patients with decay that may not be treated in one visit. It's difficult to treat dental carious lesions. Patients who with no access to dental care would be good for that. Advantages, it's non-invasive, it's no needle or drill required, it's a karyostatic agent, reduces dental hypersensitivity. Contraindications, those are allergic to silver or pregnant or breastfeeding. It also, when using this, you could have raw areas on your gingiva or sores in your mouth. Then there's self-applied fluorides. Indications. The patient needs are determined as part of the total care planning, and so the type depends on the individual patient needs. We at our clinic here do not give them fluoride to self-apply at home. We never give them one of those packets even and say here, maybe the patient's late and they need to pick up their child from school. You're just finishing and they're like, gosh, can I just take the fluoride and go because I'm going to be late? No, you cannot. We don't give them anything. We don't want to be liable for anything that they may do, or if their child happens to open it and get it, suck down all the fluoride in that thing or whatever, if they're a baby. So anyway, no, we don't give them that. When you're in private practice, we had propensity, we knew our patients and we may give them one with instruction depending on the case. So certain patients may need multiple procedures combined with professional applications. You can have tray, rinsing, and toothbrushing. A tray would be custom made or disposable, probably would be a disposable. If it was a rinse, the patient swishes for 1 minute, 1 whole minute with measured amount of fluoride rinse and swishing in between the teeth. If it's toothbrushing, the fluoride containing dentifrice used after breakfast and before going to bed without further eating. Use an interdental brush to apply the fluoride to proximal surfaces or open furcations. So tray technique, home application, I'm not going to go over that now. You can kind of read about that. Fluoride mouth rinses, practical and effective means for self-application of fluoride without a moderate or high carious risk. Do not use for 6 years or under, even the mouth rinses that have alcohol, particularly alcohol and fluoride. During a high-risk preteen and adolescent years, they would probably need fluoride mouth rinse for areas of demineralization, root exposure, following recession or any kind of periotherapy, maybe a school health group program, moderate to rampant caries, biofilm retentive appliances, xerostomia from any cause, hypersensitivity of exposed root surfaces, and do not eat or drink for 30 minutes when you've had that. Beware of the alcohol content for those who may be alcoholic or sensitive. There's a brush on gel and being used an adjunct to daily application of fluoride within your toothpaste and as a supplement to periodic professional applications. So it's available as gel separate from toothbrushing and available also as a paste with an abrasive system added. Requires a prescription if it's 5,000 parts per million. We have great toothpaste with 5,000 parts per million fluoride that are given to people with rampant decay or issues with radiation or chemotherapy, or just a situation to where they need help with the enamel in their teeth. It's awesome. But your dental office will sell those. We sell, there's different kinds. We sell it at our clinic. It's available over the counter if it's only 1,000 parts per million. You can get it OTC. So you spread it all over the teeth, brush 1 minute, then swish to force the fluid between the teeth several times before spitting it out, and don't rinse. So in 1960, the first fluoride dentifrice gained approval by the American Dental Association and the Council on Dental Therapeutics. It was 0.4% stannous fluoride. Fluoride dentifrice, approved by the ADA, is an integral part of a complete preventive program and is a basic caries prevention intervention for all patients. That's about the third time that that was stated in this PowerPoint, so I hope it kind of sinks in. I've seen questions about that in review books. So it's for all patients regardless of the caries risk. Patients with a moderate to rampant dental caries are advised to brush 3 or 4 times each day with a fluoride-containing dentifrice and to chew xylitol gum after a meal when they cannot brush. So xylitol gum is really good for helping for dry mouth, so they can have more saliva. Expectorate, but do not rinse after brushing to give the fluoride a longer time to be effective. So preparations. Fluoride dentifrices are available as gels or pastes. Amine fluorides are used in other countries, but not available in the United States. The current fluoride constituents that we use are sodium fluoride 0.24%, 1100 parts per million, sodium monofluorophosphate 1000 parts per million, and stannous fluoride 1000 parts per million. They can make these preparations. The requirement for acceptance of a fluoridated toothpaste by the ADA are described in Chapter 28, but you always need to look for the ADA seal of acceptance, and that can tell you a lot right there. Daily oral care begins with eruption of the very first primary tooth. You can put paste, smear, spread all, just a little smear spread over all the teeth before brushing so that all the teeth benefit and large amounts of paste are not swallowed. Usually you would take a piece of gauze and just wipe the teeth off from breast milk and or formula when they're infants. A child 3 to 6 twice daily should be brushing AM and PM with fluoride paste the size of a small pea, already spread over the filaments so that they're not swallowing any of it. Adults use ½ an inch of fluoride twice daily on your toothbrush. Spread over all the teeth with a light touch of the brush, and then proceed with brushing, but do not rinse. Fluoride preparations and fluoridated water have wide margins of safety. It's beneficial in small amounts, but it can be injurious if used with attention to correct dosage, without attention to the dosage and frequency. So you can have acute toxicity, refers to a very quick intake of an excessive amount over a very short period of time. So acute fluoride poisoning, though, is extremely rare. Chronic toxicity applies to long-term ingestion of fluoride in small amounts, and it exceeds the approved levels. Accidental ingestion of concentrated fluoride preparation can lead to a toxic reaction. A lethal dose is the amount of a drug likely to cause death if not intercepted by an antidotal therapy. So it's a good thing to keep out of, really little kid, toddler hands, because they could wind up just like eating a lot of it. Some of them bubble gum and different ones are flavored pretty nice. If that happens, emergency treatment, you want to induce vomiting. Digital stimulation means put your finger down your throat, at the back of your throat or tongue. You want to call EMS, administer fluoride binding liquid when the patient's not vomiting. So a fluoride binding liquid would be milk of magnesia, or lime water. So support respiration, circulation, and additional therapy would be indicated at the emergency room. Do you want to take 10 minutes?
Yeah, that's fine.
I have a question for you quick.
Uh-huh.
For question number 8, let me find it quick. It says something about Explain the relationship between fluoride supplements and dairy products. Is it just not to take it with the dairy
Yes.
products? Okay.
Yes. The fact that dairy products bind to that, so it not very much can be absorbed.
Okay, thank you.
All right, so I will be back at 2:55. Is anyone still there?
Yeah, I am.
Okay, just quick question. Is it easier for you guys if you're looking at this in a recording, if I just keep going because it's one recording, or does it, because I could turn the recording off and turn it back on, but you'd have two different things. Does it matter to anybody?
I'm fine with you leaving it on recording and just posting it like this because we can always fast forward it.
Okay. All right. Then it Okay. Any questions before we start?
I have a question, but it's not related to this.
Okay.
So we just got an email about having to social distance, and like there's too many of us in the lunchroom, like in that like student lounge room. Do you think it'd be possible to get like the classrooms upstairs unlocked for us to like spread out more? Because other other groups go in there as well, other than dental hygiene. And so I didn't think it would be possible for all of us to be able to eat lunch at the same time and not be in there. Like, where else are we supposed to go?
Good point. Well, I have a few suggestions. You go to Seoul or Tower Tavern.
Yeah.
Yeah, I agree. I will get on that. Get back with. Okay.
Bulls just sent out an email, and so I was curious.
Bulls just sent out an email about it.
Yeah, saying that we need to start social distancing better, but we were all confused on where else is there for us to go during lunch, if it would be possible to get the classrooms unlocked.
Yeah. Okay. I'll look into it.
Okay, thank you.
Uh-huh. Yeah, where are you? You can't go in the hall. You can't go. Yeah. I agree. Okay. We've kind of gone over a little bit about the principles of instrumentation in another separate earlier PowerPoint, but I wanted to, this is from your actual book, and I want you to be able to get all the information. Don't look at the, whoops, let me go back. You'll see that chapter 37 is to slides 1 through 59. Some of them you've seen before. They'll make more sense to you now, I'm sure, than they did before you started with instruments. Don't worry about the sharpening on chapter 38. We'll be doing that part of this. I combined the two chapters. Don't be worried about this part until later. I'm not sure how we're going to do that with social distancing. So usually I have these together, but we'll see. So just worry about the 37. You know, the instrument ID recognition of instruments you need to know by sight and by numbers. I think some of them you probably know a little better now, but by sight. But it would be a good idea to get the numbers that we use down. I don't have any questions about that on my quiz, but it would be a good idea throughout the program to get those numbers so that when we say as instructors, hand me your 533, that you know what that is. So just something to keep in mind. Classification of instruments are by purpose and use. The probe and the explorer, of course, are examination instruments. Treatment instruments are your curettes and your sickle scalers. Description on the instrument handle, it's design, name, and numbers made by different manufacturers. That's why they have different numbers. And of course, you have your working end, your handle, and your shank. Straight anteriors, they're always, I think, at least the groups that I was working with, I hope the other instructors were always pointing out the straight and shanks are for the anteriors, and if they're angled, they're posterior. And the more angled that or contra-angled, they call those contra-angles instruments, the more angles that it has, they're usually for hard to reach areas or posteriors. The lower or terminal shank is always parallel to the long axis of the tooth. And flexibility on the shank. Rigid, thick shanks are heavier and stronger, and they don't flex. So they're for heavy calculus. And the less rigid, the more flexible they are, and it provides more tactile sensitivity for fine deposits. So your Barnhard, which has that really long shank, it's really strong in through there and thick, and that's for really heavy calculus. And like your Gracies are not as thick and strong, and so you get more of a tactile sense that vibrates through the fingers as long as you don't have a death grip. So the overall design, single-ended instruments have one working end, double-ended instruments have two working ends. Lighter weights increase your tactile sense and less hand fatigue. Diameter, best 3/8 or 5/16 inch and should be hollow. Texture, need to have serrations. They can be smooth, ribbed, or knurled. Smooth is always avoided. Yeah, I don't think they really make any of those anymore. And here you can see where this is all textured, but we used to have, they were all smooth. So here's diameter. You would need to keep within these two. We used to, in the 70s, work with these two. Instrument features, balance. The working end of a balanced instrument is centered in a line with a long axis of the handle. So it'd be like that. They center it, each instrument, in its own way with the handle. Categories, you have supra and sub. Supra, even though you can use your curettes, supra as well as sub, they categorize your pointed instruments, your scalers, as supra, and your curettes that have a rounded back as sub. Scalers and curettes are then divided by blade anatomy. So the curettes have a rounded toe. You have a universal, which has two cutting edges. It's like one big long cutting edge. This is how they define it and how they'll say it in a question. It's like one big long cutting edge all the way around, interrupted by a rounded toe. And that rounded toe in the middle of the two sides that are blades on the universal is also sharp and can be a cutting edge. Then you have area specifics, minis and micro mini bladed instruments. And these usually have just one cutting edge on one side or the other, and they're angled. The face is angled, kind of on the diagonal. The scalers, a pointed toe, your sickles, your jaquettes. The jaquette is like the triangular end. You have a file, a hoe, and a chisel. Now, I didn't really go over these much before, but I think you need to know these. I see them in the questions. They're at least in multiple choice questions that you have to choose from, even if they're not the right answer. So why we don't hear much about these anymore is because the Cavitron, the ultrasonic tips, came into being. And so as we're using those, they've taken the place of the file, the hoe, and the chisel, which before that Cavitron, we took, I don't care how bad of a case that it was and how much calculus they had, we had to take it off with hand instruments. And so for the really hard, thick, heavy pieces or bridges of calculus that were all over just one continuous, from canine to canine on the linguals of the lower anteriors, we'd have to bust that up somehow and remove that with hand instruments. So we had instruments that would help us do that. So we're going to go back to the universal curette. The face is the inner surface of the blade, obviously opposite of the back. And the same thing would be for a Gracie curette with one, even though the face is on the diagonal, this face is straight across at a 90-degree angle. It's flat like this. And even though the area specific curette is angled, still the back is on the opposite side and of the face. So here's that one continuous cutting edge around the face, because the two sides are united without interruption by a rounded toe. Just seems a really long way to explain that, but that's what they do. I know these angles On the inside angles, particularly for boards, 70 to 80 on a curette. And once again, they also spell a curette this way. And Beckerly would like us to actually spell the curettes with another T and an E on the back, so both are correct. Stability, you must maintain control by using a proper grasp and fulcrum, which is your finger rest. Your dominant hand has the instrument, your non-dominant hand has the mirror. A rigid grasp produces tactile sensitivity. I'm sorry, that is not true. A rigid grasp does not produce tactile sensitivity. You cannot feel a lot when you have you need to have a firm but very light grasp. I need to change that. Control results for less patient discomfort and less fatigue to your fingers, hand, and arm, and actually shoulder. This is a palm grasp. A lot of times they'll say if you can use your mirror handle in a palm grasp, it will and pull the cheek back for just to pull it back and keep it there instead of using your fingers. It's better for your carpal tunnel and all of that. It's just really, really hard to do. Most of us don't use a palm grasp when we are using our mirror, but it's a good thing to do. Handle the instruments held in the palm by cupped index, middle, and ring finger and little fingers. The thumb is free to serve as the fulcrum. Limited use, it's not for deposit removal with instruments. Examples, you could use a palm grasp when you're just using the air syringe, if you're putting in a rubber dam clamp holder, if you're using a chisel, or you're just sharpening. And at least it would be a few ways that you could use that palm grasp. Modified pen grasp, 3 fingers grasp of thumb, index, and middle finger all in contact with the instrument. The center of the pad of the index finger and thumb, the inside upper corner of the middle finger is placed on the upper portion of the shank. So roll of the middle finger is not held across the nail or side of the middle finger. Roll of the ring finger, finger rest or fulcrum, side to side contact of all 3 fingers. So this would be your left-handed once again and your right-handed of how you would be using. There's a space in between your index and your thumb in order for you to be able to rotate. Neutral positions. Neutral positions we should always try for. Neutral positions mean that everything is straight. We can have reduces the occupational pain risks and prevents trauma disorders, especially carpal tunnel. So your wrist to be in neutral position should be straight and not cocked up or cocked down. And forearm and hand, your wrist, forearm, and hand are in the same horizontal plane. Carpal tunnel brought on by pressure on the median nerve in carpal tunnel from a rent vest. I'm talking too much. A bent wrist. Your elbow should be 90 degrees horizontally or slightly oblique. Shoulders should both are level and relaxed and parallel with the floor. Finger rests, support on which a lever turns in a moving body. That's a fulcrum. So your finger will pivot. Objectives, it's for stability, unit control. Your whole hand moves as a unit. It helps to prevent injury. It's for patient comfort and control of your stroke length. Limits instrumentation to exactly where it's needed when you have a fulcrum. So a bent wrist, this is what I mean about it cocked a little bit. You cramping the median nerve, and that was supposed to be median a while ago, not medium. This is a neutral position in straight line with the forearm. And if you're noticing it not being in a position, start moving your chair. Just start sliding your chair on those wheels one way or the other, and it will straighten your wrist out. So the definition of a fulcrum. is the point on which a lever rests or is supported and on which it pivots. Stability, a fulcrum provides focal point from which whole hand and unit can move. It allows controlled action, prevents irregular pressure and injury to the patient's oral tissues. The patient may sense a securely applied instrument, which may increase their confidence in your ability, and limits instrumentation to where it's needed, once again. Intraoral finger, digit used for the finger rest, ring finger. Location selected for convenience of the area of instrumentation, stability and control, safety of the clinician and yourself. First choice for a fulcrum is the tooth or teeth adjacent to the tooth being treated. The chin, lips, and cheeks are mobile and flexible, so they aren't the best. The rest should be on the same arch or quad as instrumentation. So I don't really know how they're going to handle this on boards, because this was always the old way for, 40, 50 years. The teeth were, the chin, lips, and cheeks are mobile and wouldn't be the best. But later in this very same chapter, it's talking about the fact that the extraoral fulcruming is the way to go now to help the clinician out and for the patient. So there you go. But extraoral fulcruming didn't used to be a good thing. That's why instructors are saying, you need to learn how to go inside. I disagree with that. I think you need to, well, no, I don't disagree with that. I think it's good to figure out both ways in case your patient is minus some teeth or whatever, and you have to use a different either extraoral or intraoral fulcrum on those back molars. But if you have a choice for your own sake and the sake of your patient, I would go extraoral. And I say sake of your patient because if you can get your instrument positioned more correctly behind the distal of the last molars and remove their, you have better fulcruming and wrist action, in other words, strength to pull, use a pull stroke and remove that calculus. And sometimes when you have an intraoral and your fulcrum is on like the maxillary teeth, maybe around the canine, and you're trying to reach all the way back to the maxillary last distal of that molar, you can do that, but you can't, a lot of times it's not a lot of strength that's pulling that off, which means you're going to be scaling and scaling and scaling, which just prolongs everything for your patient. So intraoral fulcrums cannot always be established in areas too difficult to access. So here we go. Extraoral may be more effective. Maximize the contact of the clinician's instrument hand with the patient's face. Cheek and chin are most commonly used. So see, before it said they weren't, they're mobile, which means it's not very stable, but I have not found that really to be the case. A secure fulcrum is dependent on the pressure against the face and underlying bone. The grasp on the instruments will need to be modified so that it's farther from the working end than what is used with a traditional intraoral fulcrum. Then there's alternative fulcrums, limitations. If you have limitations because of their oral anatomy, maybe they have a huge tongue, macroglossia, and the tongue is so in the way, and we get tongues that follow. They don't mean to, and they're not trying to. They're trying to help you out, but their tongue is following your instrument, which means it's covering it, that or the mirror. You can have malocclusion, physical disability, trismus, where they can't open their mouth very wide, or someone with just really a small mouth, and it's hard to get in there. So you have to use some alternative fulcrums in that due to all these. Also, check the height and the position of the patient's head on your chair. Sometimes that can be, they can slide down or slide up a little bit, and that can make a big difference. You can use a substitute fulcrum, cotton roll. You can put a cotton roll around a missing teeth, and then fulcrum on those if there's a missing tooth, and that's right where your fulcrum, where you know to go. So you may need to fulcrum on the opposite arch, but you never ever place a cotton roll or your fulcrum on a mobile tooth. I think that goes without saying, but I'll say it anyway. Supplementary you can use is usually supplementary fulcrum means a finger on a finger. So I could put my, if I was right-handed, I'm doing the facials of the premolars and molars on the lower right. So I'm sitting there, and maybe they have a small mouth. I can put, instead of the mirror, I can put my index finger or thumb, whatever, in on a tooth, and then put my instrument fulcrum on that finger and get on the back. If that, does that make sense? And we can show you that as we're going around. Ask your instructor to show you a finger on finger rest and how you could make that happen. Hard to explain. Index finger of your non-dominant hand placed on adjacent finger. Use your thumb on the shank of the instrument for support. So touch or pressure applied to the finger. You need to balance the pressure. The effects of an excess pressure or a death grip or pressure that you're fulcruming with and you're pressing down on their jaw is you have a decreased stability, diminished control, then you have an over-tightened grasp to try to accommodate all that, and what you wind up with are pain and fatigue for the clinician. And the patient also has fatigue caused by the use of the mandibular fulcrums, because heavy pressure on the mandible can cause their joint pain as well as your own fingers. Oh, I already did that. Okay. Purpose of the fulcrum, I think I went through that. Carpal tunnel, fulcrum. I don't know how I got so off. Oh, I'm going backwards, aren't I? Okay. Adaptation. You always want the side of the tip of the instrument or the toe of the instrument, however you want to verbalize that. It's a well-adapted instrument when you do that. The working end, 2 to 3 millimeters of the toe if you're on a flat surface. Less than 2 millimeters on a narrow surface. Usually you're looking at less of the tip, and also when you're on line angles. On line angles, when you're going around a tooth, a lot of times it's hard to have 3 millimeters of the end of that tip. You may only have 1 or 2 millimeters as you're rotating the instrument. What you want is no soft tissue damage. Problem areas are the line angles. You roll the instrument on convex and rounded surfaces, cervical area, and proximal or interproximal root surfaces. So maintain the side of the tip on the tooth with a long axis nearly parallel with the tooth. Explorer is the side of the tip. Scalars and curettes, angle formed by the face at the cutting edge of the instrument. Zero angulation is when the face of the instrument is flat against the tooth. And they're saying for test questions that when you put, and let's say one of your patients had a 6 or 7 millimeter pocket or whatever, how you put the instrument sub-gingival is that you make the face flat against the side of the tooth while you're going down. When you get down to the bottom, then you open it up. Few people do it that way, actually, but that is what zero angulation is. For curettes and scalars, you want to open it up to 70 degrees to the tooth surface. You put light, moderate, or heavy lateral pressure, pressure against the tooth while you're doing your activation stroke. So this would be 0 degrees. This is the end of the tip with the instrument going up somewhere around the back of there, and you're just seeing the tip. They want you to put it flat while you're going down here. Then once you're down there, and go over any kind of calculus deposit, and then you go to the bottom of the calculus deposit, and then you open it up to 70 degrees and you pull it out. This is what we used to do when we had a diseased pocket and we did curettage. That's pronounced curettage. And gingival curettage was a big thing during the 70s and maybe early 80s, 60s, 70s. And so they wanted you to remove all the calculus here, but then take the other side of an instrument. You can tell this is flat across, so it's a universal. And there's a cutting edge here and here. So you would, with one edge, you would take the calculus off, and then with the other edge, you would just slightly go up. And this looks like you're scooping up a lot of their tissue, and it would like really hurt, but it isn't that way. It's taking off that very fine little bit of tissue, because it was all, the idea was that it is infected. And so let's take that, get that all out of there and get the calculus and biofilm out of there, and then a nice fresh piece of tissue hopefully will adhere back to the tooth and close that pocket a little bit. But what happened was, as soon as they would take all this out, when this goes back on there, it shrinks a little bit as it's hugging next to the tooth. This is like really way and above. Well, that's the root, but it would shrink. And so people would wind up with a lot of recession, etc. And they didn't really find that it did any different than leaving it there. So why not leave it there and not take off that tissue? So now it's not done. A stroke is unbroken movement. So identified by the instrumentation being performed. So you have a probing stroke, which is your walking stroke you would do with a probe, or a root planing stroke. The types of the stroke by action, you have a pull stroke, a scalar removing calculus, a placement, exploratory when being positioned. So you place it, maybe the probe, and go down there, place it at a certain spot, like your get ready zone, your distal line angles, and you're kind of just feeling the tooth on your way down. Then you have a push-pull, which is an up and down movement. It's a walking stroke. The probe is up and down, but we don't really, I guess you push and pull it, but there's also an instrument that you're going to see here soon that you would put a lot of pressure. A probe, you're not going to put a lot of pressure on your push and pull. Tip is in the tissue, so if you don't have that over here, and it would be hurtful, this would be the cull area, like maybe the buccal is on this side and the lingual's on this side, and you've got these teeth all together, and you're going into the interproximal area. And if you don't have, a lot of people look right here and right here. That's where they're feeling on the blade, and this is just sticking out. Well, like here, they're feeling this on the blade, and this little tip is sticking out. So you have to kind of back that up and make sure that just the last couple millimeters are the ones that are in contact with the tooth as you round the corner and go anywhere else, and then you won't be hurting your patient. So an activation stroke, scalar or curette, it's light, then more firmly down during the movement. Explorer and the probe are to be held lightly at all times. During a stroke, the whole hand pivots and rotates on the fulcrum. It's generated by unified action of the shoulder, arm, and wrist. And short, controlled strokes, controlled, decisive, and directed to protect the tissue from trauma. Avoid long strokes if only a small amount. limited by the extent of the calculus and the anatomical features. So stroke characteristics, types of stroke by function. You can have an assessment or exploratory stroke where you're just holding it light to detect irregularities like calculus, decay, overhangs. You can be probe, explore, or cavitron tip. You can not turn the cavitron on, but just use the tip, and it can kind of go down like a little explorer of sorts. Short strokes, diagonal, vertical, and horizontal. Circumferential, they use the word circumferential, not circular. So if they say, if a question asks you something about scaling a tooth circumferentially, they're talking about all the way around in a circle. They just don't use the word circular. So these are oblique. This is down by the bottom of the pocket depth. And here would be the gingival margin. And you can kind of go sideways, straight up and down, horizontal. Tips are to a sharp point on scalars, 2 cutting edges on a curved blade. The face is flat and the back is curved. So internal angle is 70 degrees. Straight jacket or scalar is at the opposite end of your rounded sickle or scalar. 2 cutting edges on a straight blade, and the face is flat. And angulation, straight, usually anterior teeth and premolars, of course, and modified or contra-angled on your instruments would be, as you know, posterior teeth. So here's your sickle scalar. It has that curved back, and ours isn't quite that curved, but it's going to be triangular if you did a cross section of it, but it is to a point. Here's your face and sides. So the straight scalar, here's a straight scalar. It's just perfectly straight. There's no angles going this way or that way. Triangular cross section. Oh, wait a minute. Yeah. Okay, there's the 70 to 80 degrees on those inside angles. So supracalculus removal and slightly below the gingival margin are what pointed scalars do. When the calculus is continuous, with just a teeny bit of calculus is continuous with a supragingival, you can go sub. Subgingivally, if you go down too far, you're going to have tissue trauma with a pointed instrument because it doesn't have a lot of angles and it can't be adapted to the contours, rounded corners of a tooth. Tactile sensitivity decreases with larger, heavier blades and a stronger hold. Angulation, the face of the blade of the tooth is at a 70-degree angle. So when you're going down, I would know that 70-degree angle when you go take an instrument down underneath and then you open it up, it should be at that 70 degrees, the face to the tooth. So you do a pull stroke and overlap. On a universal curette, there's paired mirrored images on a single handle. You have exactly the same image on both sides or blade. The blade's 90-degree angles to the lower shank. 2 parallel cutting edges on a curved blade, sharpened on both sides and around the toe. So the internal angle is 70 to 80 degrees. The shank angles and curves are specific. Purposes and uses, calculus and root debridement for patients of all ages. You can use that. So it's ideal for removing large pieces of calculus quickly across multiple teeth. Calculus and root debridement for patients of all ages. Standard instrument for subscaling to be followed by root planing with a Gracie curette. So what we would do is go down with a universal and then we would fine scale. We call it fine scale or root plane with the Gracie curette right afterwards. So What I would do would be, if I have someone with really heavy bridges of calculus, is to first take an ultrasonic if they can have that used on them. Then I would take a universal, and then I would take maybe a Gracie if there was anything left. Removal of supracalculus, especially in pediatrics, a universal curette is good for. The rounded back is best adapted to the cervical area around the gingival margin. Does not traumatize the gingival margin on the base of the sulcus or pocket. So here's your universal. On your outside angle is 90. Your inside angle is 70. And also it's 70 from this blade to the tooth. So it's 70 from the shank to the blade and 70 from the blade to the tooth on a Gracie and on an area specific curette. This would be a 90-degree angle from the blade to the shank, and you're going to open it up at a 70-degree angle from the blade to the tooth. So each curette is designed to be adapted to specific areas on your area specific. The face is offset. One long sharpened cutting edge and the sharpened curved toe, and then it stops. So it's just one long instead of two long on the universal. Only the lower outer edge, when the handle is held vertically, is sharpened and used. So these are perfect for SRP. The one blade is applied to the tooth so that the face forms a 70-degree with the tooth. Toe third of the cutting edge is on the tooth surface, and on line angles, only once again, maybe one or two is near the toe. Advanced area specific curettes, there's variations of area specific curettes, and they provide clinicians with greater opportunities to complete advanced instrumentation, like in really deep pockets, within curvatures of root surfaces. These curettes are awesome in curvatures of root surfaces because of the way that they're angled. The advanced ones, they have these after fives, mini fives, micro mini fives, curettes are all different variations that adapt to the curvatures of the root better with moderate to, when they have moderate to severe attachment loss, and infurcations of multi-rooted teeth. So objectives is for deep pockets of these mini blades and micro mini blades, curvature of the roots, multi-rooted teeth, single-rooted teeth with moderate to severe loss of attachment, could be on a single-rooted tooth for sure. The terminal shank has been elongated by 3 millimeters. And the mini blade, the blade is half as long as a traditional blade for root concavities. So the blade itself is not as long. It's a shorter blade and a longer shank. Those are great for little tiny crevices and furcations, etc. Micro mini blades, or even the blade is half as long as a traditional, but which is the same as the mini blade, but now it has micro on it, which means it's actually narrower blade and 20% thinner. And it has increase in rigidity of the shank to allow pressure for very deep calculus removal. So it's much, much thinner. Some of these, if you look at our blades, some of the pockets that we deal with are not that wide. And so they make extra advanced curettes to accommodate that. Universal curettes are used for subgingival scaling for removal of as much calculus as possible. The design of the curette is with a slender shank, a rounded back, allows entrance into the sulcus or pocket with minimal trauma, tissue trauma. The stroke is you use a pull stroke. You don't push it down, you use a pull stroke up. You let it go down softly, you hook onto a piece of calculus, and then you pull, you get lateral pressure, which is to the side of the tooth, and you pull off the calculus, either vertically, horizontally, or oblique. Then here we go to the file scaler. The file scalers that we used to have, they could be metal or diamond, reduced tactile sensitivity due to a series of different blades on there. There'll be a series of little blades on a file. It was to remove calculus. It crushes and fractures calculus into little fragments, which is what the ultrasonic also does. It's for burnished calculus that someone has smoothed over thinking that they got it off but didn't, and it can get in there and crush it. It's for gross deposits, meaning huge deposits, when ultrasonic is contraindicated. Maybe that patient can't have the ultrasonic for some reason, and so then you could use one of these. It's smooth CEJ or overhangs. It's placed flat with a pull stroke and followed with a curette to leave a really smooth finish. This is a file scaler, and all these blades are at a 90-degree angle, or this blade is at a 90-degree angle to that shank. And it's just what it just crushes it. Then you have a hoe. Don't laugh. Everyone's going to laugh. You have a hoe scaler. So this blade is single straight edged. It has a thick blade. The purposes and uses: supragingival, large tenacious pieces. Contraindications: you don't use it subgingivally. It can really gouge. You have full width at the cutting edge in contact with the calculus, two-pointed contact at the cutting edge and the side of the shank with the tooth. This is a hoe scaler, and it looks like this. Like a little short, squatty, chopped off. I was going to say shovel, but I've never seen a shovel quite like that. But this is how you would put it on a tooth, and it gets underneath the calculus, and the cutting edge is on the top. It's this top blade is the cutting edge, and it just rips that calculus right off of the tooth. Then you have a chisel. It's a straight cutting edge. Blade is continuous with the curved shank. The end of the blade is flat. It's for supragingival calculus from exposed proximal surfaces of anterior teeth. Horizontal push stroke from facial to lingual. It helps take off a bridge of lingual calculus on the mandibular anterior teeth. You apply full width of the edge so it won't gouge. This would be a chisel, and the cutting edge is on the back. You just put it on a big bridge and apply pressure, and it does that. And in place of all those, luckily for you, we now have the ultrasonic. So detection of instruments, assessment stroke means a rehearsal stroke. You're going down there to just assess an exploratory stroke with an instrument or an explorer or the probe to just feel what's there. So a scaling or working stroke, you have a firm control. A root planing stroke, you're using lateral pressure. Once you hook onto the calculus, then you're going to put pressure against the tooth with your fulcrum and pull it off that way. A root debridement stroke is like that, but lighter. As a root is debridement, what we're trying to do is not take off this cementum. So errors in technique: if you use insufficient pressure because you're afraid of hurting your patient, you're going to hurt them far worse medically because you're going to be burnishing the calculus, and then it's just really hard to get off. If you use excessive pressure, you can gouge the root, potentially damaging to the soft tissue. The patient is in discomfort because of the pressure on their jaw and their mouth and everything else. They're fatigued and you're fatigued. All of the following are objectives for using an assessment stroke with a curette except one. Which one is the exception? I think that's pretty obvious. Okay, so remove fine calculus subgingivally. We don't remove calculus with an assessment stroke. If you are going down there to assess and then you feel a piece of calculus, now you've changed from an assessment. Even if you don't take the instrument back out of the sulcus, you have now changed from an assessment stroke to a working stroke. But an assessment stroke doesn't actually remove calculus. So factors that influence the selection of what stroke you're going to use are their gingival conditions, what the surface of the tooth feels like, whether there's demineralization or whether there is decalcification or what's going on, probing depths, instrument design, and the nature of the deposit to be removed. Is it light? Is it heavy? Is it a little bit? Is it wide? You know, whatever is going to determine what instrument you're going to choose. Once again, on assessment, the pressure is light. Calculus removal, you activate the working stroke. You're going to increase firm lateral pressure against the tooth. The fulcrum pressure is also firm for stability, but not heavy. Maintenance for root debridement, pressure is responsive to the tactile information transmitted from the instrument as it goes across the tooth surface. So as you're going across, you may feel a little bit of calculus there, and so you apply a little more pressure. Now you're feeling, and you're moving right across the tooth. Now you don't feel much at all, so you don't apply a lot of pressure. So it's a matter of applying, not applying, and applying and not applying, which really means that you're squeezing your instrument and unsqueezing it intermittently along as you go, as well as when you're doing strokes with your instrument. So it's going to increase and decrease your pressure. Squeezing a therapy putty soft ball can help with dexterity development. For strength and control, hold putty in a palm, grip with the thumb and fingers, tighten and release it at regular intervals. Visibility, hopefully your loops will help out with that. Helps to maintain your posture, less tooth or tissue trauma, and shorter appointments because you're moving faster because you can see well. Stretching strengthens the finger and hand muscles. You can use rubber band on the finger joints and just spread them out and in. A band on joints with the use of fulcrum variations. Here it goes, squeezing it back and forth. Practice to correct modified pin grasp. You can use circles and vertical lines using mouth mirror and everyday penmanship. And Monday, I'm going to bring you a geometrical sheet, which helps with you guys at home. Some of you are having issues with looking indirectly into the mirror while you're trying to use an instrument. And this sheet I will be showing you, this sheet that I will give you will be great practice for you at home to correct your modified pin grasp, and it'll have circles and vertical lines all over it that you can use with the mirror. I'll show you. Prevention of cumulative trauma, posture, and repetitive motions. Exercise will improve all of these. Exercises performed chairside between appointments. You can stretch your fingers and wrist before picking up the next instrument, even when your patient is in the chair. So even if you can't get up and do big exercises, if you even shrug your shoulders, roll your shoulder and then the other, your wrist roll is great, and finger stretch out. This is what you can do with a rubber band placed right around this part, and stretch your hand out and back in and out and back in, and shake your hand. That helps. Stretching fingers prior to usage. You can have it on your instrument and just spread out your fingers and do a little exercises that way. Any questions about those? We're not going to finish this, obviously, but I will record them in this chapter. There's just one thing I want to go over with you about this while you're all here. I want to explain the hydraulic theory and what this is doing, which will help make the whole chapter make sense. This is on sensitivity and hypersensitivity, which you're going to be dealing with a lot. And so this is how it's done and why it gets sensitive, which will help you understand your patient a little better and help maybe be able to suggest some things that might relieve that. So here's a tooth, and they just took a cross section right here of this tooth, and that's what this picture is. So we have the enamel, we have the CEJ right there, and we have the root surface right down here. So you have all of these endings. You have these tubules. See all those little tubules that run in through here, and they're also on the enamel actually. And they run, it's throughout the whole dentin here, and the pulp is right in the middle. So we have the root surface, and there's it's called a smear, and it's will be in this chapter as well. It's the smear of what, like when we scale and we are scaling all around a tooth, and we have some deposits and kind of saliva and whatnot, probably epithelial cells and whatever on our instrument, and we're still just keep instrumenting across here. It's actually kind of smearing that with a little bit of that, and it's called a smear, and it's a protection. You kind of can protect these, the root surface, and then cementum is over that. And so we're hoping that that is protective. But let's say all the cementum is gone, which you'll see on many patients. Their cementum is already gone. They've had so much recession, etc. And so all of this is exposed to the environment. So you have these tubules, and then they go all the way. Here's the pulp in through here, and you have these odontoblasts. Remember, odonto is anything dentin. So a melloblast is anything enamel. So you have these odontoblast cell bodies, and they're at the ends of all of these tubules. And what's in the middle is fluid. It's dentinal fluid in the tubule. So and then the nerve is running here, and a little piece of this nerve wraps around those cell bodies in here, and it will go ahead and wrap around. So this is what happens. The patient gets recession, the cementum is gone, the smear layer maybe there's not much of, and it's gone, and then they eat sweets, or they put their fingernail up there. They feel this little gap, because in reality, this is probably just millimeters, maybe even 3 millimeters long. So they'll put their fingernail up there, and that will hurt, or they have cold water or air, that hurts. And the hydronite, what happened is they came up with tons of theories. And I'm glad to see that they took all those other theories out of this text, because I never had anybody. They had tons of theories that were long to read. And the one that still remained the most popular with the dentists in the ADA and whatever is the hydrodynamic theory. Hydrodynamic, you can guess it has water or fluid in that name, hydro. And there's dentinal fluid in here. And so when cold or anything gets on these, it moves the water. The water and fluid kind of makes a little flutter. And when that flutter happens to any kind of stimulus out here, then that water is moving, and that hits the nerve, and it goes right into the nerve right here, and the patient hurts. So this is how it transfers, and that is how they really believe that they're getting sensitivity. So when you hear about toothpastes and whatever that can help for sensitivity or different things that they have, what they're trying to do is they're trying to close, cover up these little openings. And when biofilm or calculus gets on these openings widen and become larger. So it's going to take less stimulus, whether it's thermal or fingernails or cold ice cream or your instrument, your metal instrument when you're trying to scale this person. It's they're larger, and when the biofilm is off, then they become smaller. There'll be a picture in there of kind of what it looks like. But this is kind of, the pulp is very, very highly innervated. So you can see the pulp's got nerves running, little pieces of nerves running out. Does that make sense? Does anybody not understand that? Okay. So what I'm going to do is I'm going to go ahead and this would be a good place just to let you go on. I will go ahead and record this and put it on. It's not very long. Here's a picture of those open dentin tubules and partially occluded. Occluded means closed, so they're only partially closed in the center. And there's all these little tubules. And biofilm is going to make them grow 3 times the size of what they started out to be. But at any rate, I'm not going to record this right now because I've had a request to explain better the medical emergencies paper. If I can help out with, so the people that are interested in having that explanation, you can just hang on and everybody else can go, and then I will hopefully have this on, I'll have it later tonight. Or I guess not tonight, I guess we have a long time before then. I'll have it not too long. Any other questions?
No, I don't think so.
Nope.
Nope. Okay. All right. Well, thank you. Thank you for coming.
Thank you.
And I'll see you. I'm excited to see you guys again. I feel like I haven't seen you for like 3 weeks. It hasn't even been that long. So I'll see you on a Monday, but I will actually talk to you tomorrow for our 111. But I won't get to be with you guys till later. And I'll double check on the lunchroom.
Awesome.
Okay,
Thank
thank
you.
you.
Uh-huh. So I'll give everybody about 5 minutes or so. If you are like, let's meet back at, let's do 10 minutes. Let's meet back at 5 after 4. Just give you 10 minutes. Go get a drink, go to the bathroom, go outside, whatever.
And this is just for you to go over the emergencies paper, right?
Right.
Is this part going to be part of the recording as well, you going over it?
I can, or I can start a brand new one, or I cannot record it.
I think that I would like for you to record it. It doesn't matter if you keep going or make it separate.
Okay.
Yeah, I agree.
Okay. Then I'll just keep it going and be back at 5 after. Okay, you guys ready?
Yeah.
Yeah.
Okay, so you have questions, so shoot.
I was wondering, did you want this formatted like with like a regular paper? So like written with like a intro, body, and then paragraph? Or did you
Yeah.
want more of like a story of like a patient that has this and how you would approach it?
Either way, most people will just write it as a story and just include all those things, but you could write it with like put introduction and write the introduction and then, you know, each different section going down. Either way is fine, but you could write it just like the the case studies that, like I said, that are at the beginning and end of your chapters. You can write it just like a story. It just would need to be longer than that, I mean, than most of them anyway. I wish I could give you an example, but I don't have a different emergency. It would be giving someone like ideas for their paper because I don't have any other emergencies in there to kind of deal with.
Well, you said that someone had already turned it in. You said that to group B, so could you do the emergency that someone already turned in?
If they wouldn't mind.
Well, you don't have to do their paper, but just an example of like that topic.
I suppose. Let me. Okay, let me go into there. Now, when I open this up, it's going to take me out of the meeting, but I'll get right back in.
Okay.
Let me see. Oh, several more have done theirs. Okay, looks like let me check one other. All right, looks like 2 did it with headings of each thing that would be on your rubric and did a paragraph kind of on each heading. And 1 did it just like an entire story. Just included all those things in it.
So you don't have a preference on how?
No,
Okay.
no, I don't have a preference. You can do it either way. I don't think I've ever had anyone do headings before, but I kind of liked it. Once again, I like either way. It makes sure that you're including everything on the rubric because, like I said, I have no latitude on that. If it's not including something on the rubric, then I can't grade for it. But it's just saying, like, you know, your first patient of the day is, or your 5th patient or whatever, just make up a story and then give the patient's name. You can give your office name, give maybe the age, the gender, what they're there for, what you do when you first see a patient, like you go over the medical history and you check their vitals, and maybe talk about their, if they have any past dental or medical issues that may make a difference or not in your particular case. And then talk about the fact that you can, that you looked at all that, then you bring them back to your operatory, ask them if there's any changes. I mean, just kind of go through what you would do, and then you can start into the fact that at the beginning of the appointment, before they even get back there, or they're back there, or you're in the middle or end of your whatever appointment it is, if they have a 6-month cleaning appointment, or just there for a quad of SRP and they're going to get anesthesia by an instructor, or whatever it is that they're there for. Then I would start, kind of going into what that you're noticing all of a sudden that they are, showing whatever signs. I would go to your chapter and see what signs, like if it's dizziness, or they're starting to perspire, or they can't speak very well, or whatever, and start talking about that and what you're noticing. You can say you notice that they're slightly slurring their speech, their pupils. You can notice if that has to do with your particular case, and that you notice that these symptoms are very like whatever case that it is that you have. And then you will go into what you would do. At first, you're going to, take everything out of the mouth, and you're going to stay with your patient. And if they need help, you're going to ask the first available person, like person 1, to come in and take, the vitals, while you're trying to see whether you need to ask another person to call EMS or not. Some of these don't require EMS to be called, so you don't have to include that, but you're just going to be asking her or him, questions and dealing with however it is that particular incident is. Like, for instance, one student did a CVA, a stroke, and so this person says, as being taught in school, remembered that the stroke symptoms to survey the 3 components of the Cincinnati pre-hospital stroke scale. So you asked your patient to smile, and observed for weakness on the side of her face. You go through those things, and then you ask them to say a sentence, and you notice that they are not, complying with that and can't do it. And so you need to get somebody to contact EMS. And, at the time of the symptoms and the onset, you place them in whatever position they're supposed to be placed in for your condition, and whether you need to give them oxygen or not. And then when, and what you're actually doing for that. So, and let's see, that's going to differ between, whatever condition that you have. And then you're going to be saying, your responsibility. That's when it says the hygienist responsibility on the rubric, what is the hygienist's role in this? Then you'd be going through your rubric and kind of counting off that you've addressed each one of those things with either a sentence or a paragraph or whatever. So then the fact if EMS got there, you would be saying, then what happened, that maybe they were taken to the emergency room, or they were not taken to the emergency room, they were dealt with right there. whether they needed someone to take them home or not. Then after they get home, that, you know, that you do some kind of a follow-up and all of that. So it's just going right through all of that rubric. Then just kind of ending there, and of course having your questions and qualifiers, and be sure and I've had some people do a paper and not put their name on it, and I want you to do that. I know I've got it in here under your name, but it's better if, you know, CODA would come and happen to print something off, that they would have that on there, just saying. So then you would have your resources and things for further readings and all of that. Just go right down that rubric. So you're going to give a history of your patient and what they're coming in for. Then you're going to explain that something happened, that they started having the symptoms of whatever it is that your subject matter is. You're going to say how you dealt with it and what your responsibility is on it. And you are going to, and I don't have the rubric right in front of me, but you're going to kind of make sure that everything on there is accounted for in either a sentence or a paragraph, and end up with everything that's on that rubric. Kind of end up with how it was, how you dealt with it, how EMS or the hospital dealt with it. And, you know, kind of like if you have something where they're going to need fluids, then you would say, my patient was taken to the, you know, Susie Q or whatever, was taken to the hospital where they gave her fluids to restore, you know, her condition, or whatever it is that, you know, whether they needed an x-ray or CAT scan or meds or whatever, and then that you followed up to find out kind of how it all ended. Does that make sense? Does that help at all?
Yeah, I think my main question was just on the formatting in general. I just wasn't sure how to get started with that. So that helps a lot. Thank you.
Uh-huh. And let me, and just have fun with it. I mean, don't, you know, don't stress over this. It's just make up a names and a story. And like I said, you can make it kind of humorous if you want, but it would have to be accurate. Oops, hold on. I need to. Get back in here. Okay. And for your other projects in some of your other classes, like in the law class, you have 3 projects to do, or papers, presentations, I should say, to do. And I do have examples of those, but don't kind of have one for this. Anything else?
Not at this moment, no.
No, thank you. I appreciate you staying on and helping us with it.
Sure.
Yeah, thank you so much. Have a good evening.
You as well. Go Chiefs.
Thanks.
Oh, Chiefs.
All right.